for joining us for this afternoon's installment of the NDOC webinar series. For those I don't know, my name is Daisy Gibbs. I am a PhD candidate at the National Drug and Alcohol Research Centre and your chair for this afternoon. I'd like to start off this afternoon by acknowledging and paying my respect to the past, present and future traditional custodians and elders of the country throughout Australia, and extend that respect to any Aboriginal and Torres Strait Islander people joining us today. Pay my respect to the continuation of cultural and educational practices of Aboriginal and Torres Strait Islander people. This afternoon, we're very lucky to be joined by Sarah Lani. Sarah is an associate professor at the University of Montreal and principal researcher at the Centre de Recherche du Centre Hospitalier Universitaire de Montréal. I should have pre-read that and prepared myself to not say that in French. Her research focuses on the health and well-being of people who inject drugs, and Sarah will be presenting this afternoon on age and sex differences in HCV amongst people who inject drugs. We're also very lucky to be joined after Sarah's presentation by Alison Marshall. Alison is a postdoctoral fellow co-appointed at the Viral Hepatitis Clinical Research Program at the Kirby Institute and the Centre for Social Research in Health at UNSW Sydney. Alison currently utilises quantitative and qualitative research to investigate remaining barriers to hepatitis C care for people who inject drugs. Alison will be joining us after Sarah's presentation. Throughout the presentation, we'd love to see your questions in the Q&A function, not the chat function. And after the presentation, Alison and Sarah will be attempting to respond to those questions. We'll try and get to them all. We may not be able to, but please pop them in the chat and we will do in the Q&A, sorry, not the chat, and we'll do our best. Now, I'd like to ask Sarah to turn on your camera and mic and take us away.
Okay, there we go. Thank you, Daisy, for the introduction. I'm sorry, I forgot that someone would need to read that part with the French, and I'm just having trouble turning my video on. I think the host might need to turn that on. Thanks. So just to give you the takeaway up front, my point here is that recognizing and integrating sex and gender perspectives into hepatitis C elimination research is essential if we are going to achieve the elimination goals. Okay, there I am. Okay. So a disclosure unrelated to this presentation of advisory board fees from Gilead Sciences. So sex and gender are not the same. I think most people have some awareness of this at this point, but to be very clear, sex refers to a set of biological attributes, so chromosomes, gene expression, physical features, hormones and anatomy. And sex is usually categorized as male or female, but there is biological variation in sex as well. And around 1 in 100 people have combinations of biological attributes that make them intersex. Gender, on the other hand, refers to socially constructed roles, behaviors, expressions, and identities. So gender within an individual is not necessarily fixed, and the personal importance of gender identity to an individual may vary over time. And so labels like man, non-binary, sister, girl are examples of gender identity. And gender signifiers and identities and roles vary between cultures and have varied throughout history. There are many cultures with 3 genders or 4 genders in the case of some Pacific Islander peoples. And it's often the case that people with gender identities outside of cisgender men and women have specific cultural roles and responsibilities. So my point is just that gender variation is not some kind of newfangled decadent Western thing. It's been around since antiquity, really, and is found in the, the earliest cultural products of human beings. So sex and gender are different, but they are interrelated, and both sex and gender affect a variety of health conditions and health behaviours. So one of the most commonly cited examples is heart disease. Sex differences in gene expression affect how heart disease manifests in an individual, and gender differences in health seeking and how patients are managed by healthcare professionals affect the outcomes of heart disease. So it's really only been in very recent times that these differences and how sex and gender interact to affect health have been taken seriously as subjects of health and medical research. And that's a real shame, because there are very real consequences to not paying attention to sex and gender, including delays in diagnosis and poorer treatment outcomes. And most often these negative effects have been experienced by women, because health research has taken men as the standard and assumed that results can apply to everyone. So I'm going to talk about sex and gender differences specifically in relation to hepatitis C among people who inject drugs. So I don't think it's any big news to say that hepatitis C is endemic among people who inject drugs, and in high-income countries, most new infections are in this population. In the past decade, the availability of highly effective treatments for hepatitis C has really led to a paradigm shift in how we think about hepatitis C prevention. And in fact, we talk about hepatitis C elimination as a feasible goal. So elimination of hepatitis C as a public health threat by 2030 is the WHO goal, although only a handful of countries are on track to meet that. And I would argue that to meet the goals, there needs to be a greater emphasis on sex and gender in the hepatitis C response. This is not to say that there have not been some sex and gender differences that have already received some research attention. So, for example, there is a very consistent finding that female sex is linked to spontaneous clearance of hepatitis C infection. This was one of the largest studies of this phenomenon, and you can see that around 3/4 of people of male sex cleared their acute infection, but around 1/2 of people of female sex did so. And the mechanisms behind this difference are not well understood, but it is known to be related to the sex-based differences in immunological functioning and inflammation responses. But I am afraid I cannot give you any more detail than that, as it is beyond me. Then in relation to gender, evidence has been accumulating for a while that hepatitis C incidence is higher in women who inject drugs than men who inject drugs. So Adelina Artini recently published this systematic review on this question. And the hazard ratio, you can see at the bottom there, was 1.2 with quite a narrow confidence interval of 1.1 to 1.3. It's not a huge difference, and clearly there's variation there between the studies linked to things like average age and duration of injecting. But there is something in there about the gendered nature of risk for hepatitis C. So we know that in some places, women are less likely than men to attend harm reduction services. That's especially in countries that tend to have greater gender inequality more generally. Women might avoid these services because the social cost of being identified as a person who injects drugs is greater for women than for men, or they just might not feel safe there. Women who inject drugs may also be subjected to gendered power imbalances in their interpersonal relationships. So whether that's people who inject drugs, broader and wider range of people that you interact with, or intimate partners. So there's just this layering of gender onto hepatitis C risk, such that some people experience greater risk and therefore higher incidence. I do need to point out here that most of this talk is actually going to refer to sex and gender in a binary sense. And that's because that's the data that are available. And in fact, in the review that I'm going to share results from, we had to assume that male was the same as men and female was the same as women, because the terms sex and gender were frequently used interchangeably in papers. And there was almost no data specific to people with gender identities outside of cisgender men and women. So that is a limitation of this work that I want to note from the outset. But I also want to note that looking at data specifically in terms of men and women is at least a great improvement over much of what has been done so far. So in thinking about these differences that we know about, if women have higher incidence of hepatitis C, but spontaneous clearance of infection is linked to female sex, and female sex largely corresponds to a gender identity of woman, do these two differences just cancel each other out? And if sex and gender are affecting these aspects of hepatitis C in people who inject drugs, what else might they be affecting? And then I think, what is the cumulative impact of these differences? If we implement hepatitis C elimination programs that don't take into account sex and gender differences, do we risk leaving specific groups of people behind in elimination efforts? Or might sex and gender differences at different stages cancel each other out, so we end up in a kind of gender neutral position in relation to elimination? So as a first step to answering these questions, we're currently doing a systematic review. Story of my life. The methods are fairly standard. We did do a review of reviews before our review of primary studies, just to identify things that were already well established and avoid redoing them. And then we used the usual approach to review a multitude of indicators, far too many actually. We reviewed all of the following. So risk for hepatitis C infection, which was considered in terms of shared use of needles and syringes, preferably receptive sharing, and history of incarceration, given that having been incarcerated is a risk factor for hepatitis C. And then we then looked at the stages of the cascade of care. So hepatitis C testing, treatment uptake, sustained viral response, and reinfection. Some of these we expected to see a difference, such as risk, and some we didn't, such as sustained viral response, which is just cure. And that was because treatment effectiveness is so high. And we only included studies published in the DAA era. So that's from 2012 onwards with those newer, highly effective treatments. So just two things to note before results. I had hoped to have final results for you, but the complications of life have been a real rate limiting step for this work. We do have some additional studies to add to the current analyses, but don't expect the results to change in any major way. And secondly, to reiterate, we have assumed that the terms male and men are congruent, and same for female and women. So we are still talking about a binary, and sex and gender are blurred. So when I talk about a difference, I'm not necessarily attributing that difference specifically to a biological function or a social factor, but we can hypothesize about that. So first up is risk of shared use of needles and syringes. So these are summary estimates for different recall periods, and the number of studies included in each summary estimate is on the left alongside the recall period. We prioritise data on receptive sharing, although we also have included data that did not specify direction. And there is a bit of variation here between the estimates for different recall periods. So lifetime, that estimate is bang on 1, no difference. If we look at recall periods of less than 6 months, though, there looks to be some evidence of higher risk in women. And then that 6 to 12 months estimate just kind of overlaps the null. So I don't know, maybe weak evidence of a difference over shorter recall periods, but there's possibly also just a recall bias here. I would say it's not evidence of no difference, and it's not no evidence of a difference. But I would like to look at this a little bit further. History of incarceration, as you would expect, there is clear evidence of a higher risk of incarceration in men across all recall periods. And this is really interesting, in particular for hepatitis C, because incarceration is linked to incident hepatitis C infection. But in a number of countries, prisons are also a place where you can get treated quite easily. So it might be increasing risk of infection, but it might also be putting people in a position where they can be cured. And I think that there's a lot to think about there in terms of the way we design programs. And I think I talk about that a bit later in the discussion. And then here we have summary estimates for each stage of the care cascade. So there's 2 estimates for testing stratified by the sample, whether it's a community sample of people who inject drugs or a sample of people in OAT, in opioid agonist treatment. So looking at testing first, it does seem that women maybe have a slightly higher prevalence of hepatitis C testing. And this difference doesn't seem to be reduced when we look at the samples of people who are currently in OHE. You might think that being in opioid agonist treatment would mean that everyone is getting tested, but perhaps not. But then, although women have higher rates of testing, when it comes to starting treatment, we see that the proportion of women who inject drugs and have hepatitis C that start DAA treatment is lower than that for men. Then treatment completion, we didn't expect much difference for treatment completion or SVR. I don't think there is one for treatment completion, but there might actually be a tiny one for SVR. We need to look at that a bit more, but there is a confidence interval around that SVR estimate, but it's so narrow you can't see it, but it is slightly above 1. And then this reinfection result is interesting. There was a lot of heterogeneity in the estimates for reinfection, and a lot of it probably depends on the local epidemic. But at the moment, there's no evidence of a gender difference in reinfection rates, which is different from general incidence estimates. So in addition to existing findings on a sex difference in spontaneous clearance and gender differences in hepatitis C incidence, we have quantified some additional differences in relation to hepatitis C risk and several steps of the cascade of care. There's clinical implications to these findings, of course, but I actually want to focus a little now on my main impetus for this work, which was to inform the development of infectious disease models that better integrate sex and gender differences. So applying a gender lens to simulation modelling of hepatitis C elimination. Existing models often do incorporate some sex or gender stratifications to accommodate the difference in spontaneous clearance or risk of incarceration, for example. But the findings here suggest some of the additional parameters that potentially should be stratified by gender or sex to project future outcomes in a way that more closely resembles real-world conditions. It is true that the differences that we've identified are often quite small, but what are the cumulative effects of these multiple small differences at various points along the pathway of risk and incidence and the care cascade? Do some of them actually just cancel each other out? Do others compound on each other? And I think that the difference in incarceration is particularly going to be important. Incarceration is more commonly experienced by men, and it's a place where risk of hepatitis C infection is very high due to the conditions under which people inject. And people have this sense of inevitability that they will get hepatitis C in jail. But this is also a place, in some jurisdictions at least, and New South Wales is one of those jurisdictions, there's a really strong focus on testing and getting people into treatment. So incarceration can also be a site for improving healthcare. And we really need to understand what this means, because a lot of models have been based on evaluating or projecting the impacts of programs that are undertaken in prison, and producing a projection of how much hepatitis C incidence or prevalence is reduced in 10 years' time, say, by this program in prison. But we need to understand, when we say that a hepatitis C testing and treatment program in prison will reduce prevalence and incidence in the community by X% in 10 years, is this happening across the board, or is this reduction concentrated in men who inject drugs? And so these findings can help us to better incorporate gender into mathematical models of hepatitis C elimination and determine the extent to which we need to focus on gender responsive programming and at what stages that type of programming is needed. And I should also note that in no way would I suggest that we do not offer hepatitis C care in prisons. Obviously, I greatly welcome that. But I do wonder at if we've thought through who is getting treated in that way. And then also, I just wanted to talk a little bit about some practical things for researchers that arise from this review. So as researchers in drugs and hepatitis, we spend a lot of time figuring out how best to ask questions about drugs and sexual behaviours and mental health and all kinds of topics that can be quite sensitive and need to be asked about quite carefully. But we also need to be very intentional about how we collect data on sex and gender. And there's plenty of guidance available on this topic, produced by various government agencies and also non-government organisations that work on LGBT health, for example, LGBTQ health, for example. So there's an Australian standard for collecting sex, gender and sexual orientation. And the standard can vary according to different cultural contexts, of course. So it's important to understand how best to do this in the specific context that you're collecting the data. So for studies with sites in multiple settings, it might be necessary to measure gender differently in each setting, for example. I also think that we need to do better at planning for sex and gender-based analysis from the outset rather than as a post hoc and often kind of poorly powered analysis. And I'm talking about quantitative data here, of course. And so that might mean targeted recruitment and oversampling of underrepresented groups. And, also for quantitative analysis, I think, we need to be thinking from the outset whether we need to do stratified analysis or include some interaction terms for gender. The best approach will depend on the question that is being asked. And of course, also if you think you're hypothesizing that your important variables are related to sex or gender, or some for sex and some for gender, all those kinds of questions. And then thinking about this in the context of the primary analysis, the headline paper, rather than as a secondary paper. And then in writing up findings, I think be explicit about what was measured and how, and use the terminology correctly. So using sex or gender as appropriate. I know that sometimes we're using data where the questions might have been a bit ambiguous, or you might be using administrative data and you have no control over how a question is asked. You might only have sex or only gender. And it's obviously important to be open about those limitations. That's actually all I sort of had for the kind of prepared comments. So I guess, Daisy, you would like to lead us in a discussion, I guess.
Thank you so much, Sarah. Do you want to stop sharing your screen?
Sure.
And Alison, can I ask you to turn your camera on so we're just all face? Thank you so much, Sarah. It's such an interesting presentation, and yeah, obviously such an important step in addressing the improving HCV outcomes, and just a really interesting opportunity to get your kind of reflections on, yeah, doing this kind of research as well. So thank you so much. I, as I said, invite everyone to start thinking of their keen questions, to start tracking them in the Q&A function. And to get us started, Alison, I'll ask you for your initial reflections on Sarah's presentation.
Thank you, Sarah, so much for that. That was so informative, and a topic that I think is so important that we do better job as researchers, in particular at. I'm going to just jump right in with some questions, and I feel like you're going to kill me with the first one, but I have to ask it. I have to ask it. What are some of the reasons that you believe that women have a lower likelihood of initiating treatment? What is going on?
Yeah, it's an interesting one, right? And I have thought about it. I thought potentially maybe it was linked to the whole situation of how you can get treatment in prison often, and that was what was driving that. But it's a trend that's been seen in places where you don't get treatment in prison. It's been seen in, the studies off the top of my head include studies in Australia, France, China, Spain. Like, this is a thing that is being seen very broadly. I don't know. But yeah, and I think it's really interesting that the data on testing seem to kind of align with broader gender difference in healthcare seeking, where women tend to go to the doctor more so than men. But then that drops off at the treatment part of things. And I don't know, is it, I don't know. I don't think there's enough pregnancy for it to be that women aren't getting treatment because they're pregnant. I genuinely am baffled.
And this was going to be the follow-up question, was going to be around the testing. Like, what is going on there that you would have more men being tested or greater likelihood of being tested?
Yeah.
Yeah.
So there's it looks like a slightly greater rate of women being tested. And that sort of just aligns, I think, with general healthcare seeking, or perhaps, seeing a doctor about something else and they say, oh, why don't we do a hepatitis C test, and just saying, oh, okay, sure. I think that we do need more, probably qualitative work that explores some of these motivations and things. I don't know that we've looked at it in enough detail.
I was going to ask you, and again, just a reminder that people can type in questions just so I don't feel like I'm hogging the session. I was going to ask you as well, because you've just done this review, you've looked at all this research that's currently available. What are some of the things that in reviewing all this data, that people are doing as researchers, they're doing right? And what are things that you were looking at and you were like, this is just, we keep coming across this as an example that's not ideal?
I think, generally speaking, I think things are getting better over time, but one of the problems is that a broader understanding of sex and gender as separate concepts is still fairly much in its infancy, particularly for quantitative researchers who might not be as familiar with some of the literature around sex and gender and queer theory and things like that. And so there is a lot, so many papers where people will use sex and gender interchangeably, and not really be clear about which of those they're looking at, or not theorize about which are important, whether it's sex or gender or both or some kind of combination. And so I think that's, it's such a fundamental thing, right? And I think that's probably the first thing we need to fix, is actually being clear about what we're measuring, making sure we're measuring it, what we think we're measuring, and then starting to be consistent and intentional, I guess, about sex and gender. It's a thing that we've been working on in our lab a lot, about updating questionnaires and making sure that we're, asking, it's not one question anymore, it's a couple of questions about, and we have a little preamble about, this is why we ask about sex and gender, and this is why we ask about them separately. So it's I think that's the kind of the fundamental thing, that we actually have to get that right before we can start to do much else.
Mm-hmm. Absolutely. And I was going to say, in terms of how I learned about the asking of the questions for our own research, and this was in quantitative research, was definitely from the community-based organizations who are saying, why aren't you doing this? And I was like, I don't know why we're not doing this. Let's start doing it. Because I think, just to reiterate, and perhaps a little bit less in the social science, but certainly people misusing the words and interchangeably. And I can just feel for you, if you were reviewing all that, all those studies, it must even trip you up when you're reading them to go, what are you talking about?
Yeah. And it makes it hard to then talk about the results as well. And initially we actually started to try, and one of the things we thought about putting in the review was actually whether people had measured sex or gender, but all of the papers we said had to say we don't know, and so it just wasn't very informative. I think think we're getting there. Like it's definitely, the more recent papers are starting to be more explicit about what they've measured and also how it was measured.
You pointed out the ABS guidelines for collecting data on sex and gender. How consistent are those guidelines in different jurisdictions? How often do you find that there are guidelines? Like, it's one thing for researchers to have the kind of drive to collect that data in a way that's accurate and sensitive, but I imagine that they're lacking in lots of areas. And what are your thoughts on that?
Yeah, I mean, I know that there's definitely a lot of national standards. So Canada has a national standard, and the UK has one. Like the NHS has one in the UK, and the NIH, I think it's NIH, one of the large US research bodies, has a standard as well, and I think they are generally fairly consistent. Some of the specificity around gender identities that vary, like particularly in relation to First Nations peoples in different settings, there needs to be consideration of specific gender identities there. And then, I mean, I don't know about a lot of like smaller countries, but I'm like, for example, in the Pacific Islands, where there's places that have these long existing culturally recognized third and fourth genders. I don't know if there's much sort of opportunity or like the infrastructure to do kind of like standardizing that. And then places where, again, like it's been very widely accepted for a long time that there are people who occupy a kind of a third gender. I don't know how well that's been standardized, or if it's almost like, how we sort of assume many things about sex and gender, maybe those things are assumed in those sex and gender questions in those countries already. It'd be an interesting thing to look at, actually.
An interesting space to watch within the context of HCV, but just generally. Less of a research question, more of a kind of clinical intervention opportunities kind of question about gender-specific harm reduction services. So thinking about those different opportunities to engage people. What are your thoughts, or do you have any examples of gender-specific harm reduction services, things like NSPs, overdose prevention sites, injecting facilities, things like that?
Yeah, potentially it is something that needs to be more widely implemented. So, for example, in Canada, in response to findings that women were not attending the overdose prevention sites, the supervised prevention sites, because those were places where you would run into the ex-partner who used to beat you up and things like that. So there is now a women-only supervised consumption site, injecting site. I can never remember what the best terminology is to use. And several, this one is in downtown Vancouver that I'm thinking of. And there's also several have introduced specific hours, which tend to be women and gender diverse people, specific hours. And then I think I also read at some point about an opioid treatment program that also provided specific hours where women could pick up their methadone. And it was designed to not only for kind of safety, but also because it felt like it was less of a risk of being sort of exposed as someone with a drug problem. So these are like really interesting ideas that I think need to be looked at a bit more to determine if that's necessary. Actually, this is reminding me, one of my RAs sent me an analysis this morning because we were looking at whether gender is a predictor of having an overdose in a supervised consumption site. And in Montreal, it seems that it is not. And so maybe it's not maybe they don't need to do it in Montreal, but maybe in another place it is important. And so they might need to have some kind of specific intervention or response there. So it really has to be kind of driven by local data as well, because obviously the context will vary enormously.
Yeah, great to have some data hot off the press.
I don't know, it'll probably change tomorrow because she'll probably write
so hot off the press.
To do this.
Yeah. We've got a couple of, sorry, Alison. Yeah.
No, I was just going to go right to the questions actually. So the first one is asking, with many countries not reporting data on women who inject drugs at all, do you think this would result in an underestimation of the differences between women and men in terms of HCV risk?
Probably. Because the countries that are not reporting that data are also tend to be places where women are a smaller proportion of people who inject drugs, but also therefore really are at greater risk because they are more, I guess, isolated and stigmatized as women who inject drugs. You've got that sort of the general gender inequality element, and then throwing in the stigmatization related to injecting drug use. And so short answer, yes, but it would be a lot of work to try and figure out the extent. And it might be that it affects things like risk more so than things like, some of the treatment uptake type variables. It would, I think that would be fascinating to look at in more detail.
Yeah, and the other question that we've got here, which I think is essentially, it would be a lot of work, is about so thinking about the kind of the full ABS recommended sex, gender and sexuality standards in research. So we've got those two, at a minimum, two-step questions. So you're asking someone about the sex assigned at birth and their gender, and if there is like a discordance between those two, with this, like how would you imagine this to be coded? And I know that you can't get into the head of every researcher who's doing this data, but do you have thoughts on that, and what are the implications of this?
Yeah, I do. I think it's really about looking at what is the association that you're actually interested in, and then saying, okay, well, what am I theorizing is the link here? Is this something that's to do with genetic expression? Is it hormonal? Like, is there some kind of inflammation response? Or is this about stigma and discrimination, or, the various sort of intangible gender pressures, I guess. And so kind of developing a really clear model of what we think is related to what, if that makes sense. And then it does get, obviously it gets very complicated, and epidemiology does not like small cell sizes. So there's always a difficulty there in terms of like, how do you accurately or appropriately include gender diverse people in these kinds of epidemiological studies? And that's where I think we need to have more kind of, and obviously this is really hard, but some sort of targeted recruitment, and thinking about how is someone who is transgender, say, affected by gender and sex and being, not a cisgender person. And I'm not saying I have the answers, is what I'm trying to get at.
Yeah. And I think that's kind of the point, right? It requires quite a lot more than just Sarah Lani to be able to answer these questions. Karen has elaborated on that question, which I think is a really important point, speaking about the implications of that discordance in terms of upcoding, that it does reinforce the notion of a gender binary. And yeah, I think you've spoken to that a bit.
Yeah, I think I guess it comes back to sort of causal inference and thinking about what is my model, my conceptual model of the association that I'm thinking about. Is it what goes in at this end? Is it sex or gender? And thinking about the logic behind it in that way.
Yeah. And we've got a question from longtime fan Lucy Tran, thinking about the factors facilitating or barriers to treatment uptake. How much of a factor does the panel, so Sarah and Alison, do you think that associated costs of treatment versus stigma starting treatment would play for each, say, sex and or gender?
I'm just going to read what Lucy's written to try and make sure I'm understanding it properly. Hi, Lucy. Thinking about factors facilitating or barriers to treatment uptake, how much of a factor does the panel believe that associated costs of treatment versus stigma starting treatment would play for each sex and or gender? Right, this is another really good question. I think this is another kind of qualitative one where we actually need to be asking people about this. I think, Alison, you might actually be able to answer this one better than me.
Yeah, I wish I could. Just to give like a very brief overview, I conducted some interviews a while ago with clients who had completed hepatitis C treatment and those who had not. And I think what was really surprising for me was that I did not set out to in any way conduct this research looking at gender specifically, but what came out of the data quite organically was women speaking to these issues of double stigma, in particular around using drugs, having hep C, and in some cases being a mother. So I think it's a lot to unpack, and I have to admit with this particular data set, it's been some of the more challenging work to kind of tease out. And I think because it's been a bit challenging to tease out, that might also explain why, there seems to be a little bit less research in this area, even though it is quite important. But I think a lot of us that are involved in stigma research or stigma reduction research, there's a lot going on. And I think, Sarah and I did an editorial together, a couple of editorials together. And I think even in relation, and we would say this with epi data as well, is that you're really, and I know I'm speaking to, preaching to the converted here, but there's like a lot of intersectionality going on. And so sometimes it's even really challenging when we're trying to just wrap up a paper by saying factors associated with treatment uptake were X, Y, and Z. And, we're sort of listing these groups as separate, but we know that these things are can be compounded and exacerbate the situation. And I know, Sarah, you probably came across this in your research as well, where it's, there's like young groups we need to look at, people under 30, people without housing, people with some mental health conditions, and gender on top of that. So I don't have a great answer for that either, just that we're in the thick of it, trying to find out more, I guess.
Yeah, no clear answer, I think, is probably an indication of a great question that Lucy can work towards answering over a long career. We've got another question which kind of leads on to more questions, I think, that that people probably have, thinking, I might put this to you first, Sarah, but correct me if I'm wrong. And I think that this will vary greatly by where you are, jurisdiction, like so many factors, but are there implications for pregnant people if they test positive for HCV? The anonymous attendee is asking about things like whether they're identified potentially as someone who injects drugs. Obviously, this would also relate to whether they have concerns that they would be identified as someone who injects drugs, in terms of that being a barrier to access, whether or not that is the case. but also things like loss of custody, access to their kids, and any other kind of implications that would be important to consider.
Yeah. Shall I start? And then
why don't you start?
Because Alison and I both have lots of thoughts on this. And it is a really important question because, for example, one jurisdiction in the United States, I think it's at least one, has mandated hepatitis C testing for people who are pregnant, and it does raise a lot of questions. And there's also this movement to kind of implement screening in prenatal care. And it raises a lot of questions around how that information will be used, because there is such a stigma, and hepatitis C will out someone basically as someone who has injected drugs, or even if they haven't injected drugs, it will, people will make assumptions about that. And so I have concerns about that, and particularly for women who are injecting at the time of pregnancy, and the potential impacts on custody, and I think also the impacts on willingness to attend prenatal care. This is a group that are already quite scared to go attend prenatal care because of their fears about what will happen, and a lot of shame and guilt as well. And so if we add this, and it kind of, there's a real potential to exacerbate that situation. And some of the literature I've read, not all, but certainly some of the pro screening in prenatal care has been, I think, a bit, not flippant, but has not really considered these implications fully. But I know that Alison has thought a lot about this as well.
Yes, absolutely. It's one of my favorite topic areas. So just to the anonymous person, if you type in Sarah and our names and Hep C prenatal care as part of universal screening, you'll see an editorial that we put together that was published earlier this year, where we really get into, I think, the thick of it. And I think, just to echo Sarah's point, I think the big thing really was this implementation aspect. Like, what was this going to look like on a widespread scale if all of a sudden you had a guideline that stated, we recommend that everyone who is pregnant receive a hepatitis C test, particularly when you think of quite, I'm trying to think of a delicate way to say this, quite tense, perhaps, environments in the US, where there is a lot of fear among parents of losing custody of their children. I think also something that you'll see in the piece that we really try to tease out as well, just 2 points, is that one, I mean, it's great that we're focusing on a particular period of some people's lives, but we also wanted to emphasize that it's not the only way to obviously reach women. I think quite often you find in hepatitis C research will state things that, people are lost to follow-up or missing, when in reality, people tend to be attending services daily and are perhaps not being approached to be engaged in care by this misconception that they don't want to be engaged in Hep C care. And just to also echo Sarah's point about definitely flippant, kind of simplistic sort of viewpoint of why don't we just get this going and roll this out, this particular guideline, without thinking about the implications for some of these people if they were to come back positive. And maybe that's not such an issue in some countries, fortunately, but it would certainly be, I think, a much more scary issue in others. So I think it was something that we delved into in this short editorial, but we tried to pack a lot in.
Yes, we did. And I just want to add as well that I just also do think it's kind of weird that, we've found that, because, people are noticing that women are not getting treated, women who inject drugs are not getting treated as much as men. But I just think it's so weird that the first impulse is to go, oh, we'll just get them in prenatal care. what? Like, how is that the easiest place to find women who inject drugs? Like, you're right, like they are attending services. Many of them are attending services regularly, or can be found in ways that don't require them to get pregnant first.
Yeah. Like you were speculating at the start. We don't think that the difference in men and women is that all of the women are pregnant and therefore not engaging in treatment.
Yeah, and I do. I just find that really. I think it says a lot about kind of how medicine thinks about women and the health of women as well, and how women access all kinds of care. But that's a whole other question, isn't it?
Oh yeah, absolutely. And not all women anywhere are pregnant. But if you're thinking about how to engage people who are injecting drugs, it seems like a totally bonkers first port of call. To try and get a captive audience of people who are accessing healthcare. Again, another great question that could be a future career to try and answer and help develop models of care to make those ways of engaging people safe and appropriate and enhance care, as well as improve data collection, all of those things. We're going to wrap up in a few minutes. Just wanting to ask both of you, you've covered off a lot of kind of implications for research, as well as touching on some kind of implications for service, engaging people to improve kind of HCV engagement. Do you have any final thoughts? Alison, I'll ask you first.
I just wanted to thank Sarah for this presentation, as always. It's so exciting to have you present. My takeaway from your presentation, Sarah, was certainly around the data collection and the data analysis component. And I think I'll speak for when I do epi research that I think we perhaps, because we're collecting the data, I think sometimes we think we've done our job. And haven't really thought about the analysis portion and what we're going to do in relation to Karen's point about, I'm just going to recategorize, or, I'm not happy with this small cell and let me just put a limitations in my limitations section and then that's enough, right? So I appreciate your reemphasis on the analysis portion and how we potentially could start thinking about that. And like you said, thinking about it more on the at the beginning of the research design, and perhaps making a strategic choice to recruit more people in of particular gender identities that we have not been doing a good job of. So thank you for that.
Yeah, echo that. Thank you. And Sarah, any final thoughts from you before we wrap up?
I already said everything.
It's true. And so well. What I would kind of, just to elaborate on Alison's point, I think it is a very exciting space, and exciting to see kind of more interest. And like you were saying, Sarah, that the newer papers are really kind of getting to that language and seeming to be more kind of forward planning in data collection and reporting and things like that. But it, we are not alone in being interested in the impact of gender on stigma and health experiences and things like that. And being interested is an opportunity to engage people who are experts in kind of that planning phase of research. And it takes a village to do great research. And so, yeah, great opportunities for collaboration outside of your specific area of expertise or competence as well. But yeah, thank you, Sarah. It's really interesting to get the perspective of someone who is in the middle of this research and what your thoughts are on how to do it well, and to give your great takes on that. So yes, thank you. And having said everything, is there anything else from you, Sarah?
No, I don't think so, mostly because I have a plane to catch.
All right, well, thank you so much, and thank you everyone for your questions and for joining us. Thank you so much, Alison. It was really a great opportunity to have two people who have clearly been engaged in this conversation for a long time do so publicly. It's always a privilege to be witness to experts talking about what they like to talk about. I will ask Laura to share the upcoming webinar slide to promote the next few weeks. So next week we've got a great presentation. I saw a teaser of it yesterday from Liam Atchison, a PhD researcher at NDARC, talking about pharmacological management of acute methamphetamine withdrawal. On the 10th of August, we've got Professor Shane Dark, book your tickets now, talking about characteristics and circumstances of volatile solvent misuse related death in Australia from 2000 to 2021. And on the 17th of August, Associate Professor Julia Lappin will be speaking about the potential of stimulant drugs such as amphetamines to induce or aggravate psychotic experiences. And then in late October on the 27th, again, book your tickets, please, to the NDARC Annual Research Symposium. Thanks again, everyone, for joining us. Thank you so much, Sarah and Alison. It was a privilege to have you. Have a great afternoon.